If menopause has hit you harder than you expected, emotionally, physically, or mentally, you're not alone. Today's episode is packed with expert-backed advice to help you not just survive perimenopause, but truly thrive through it. You'll hear about hormone-related anxiety versus depression, menopause after cancer, and what support and treatment looks like, how movement, muscle, and mindset can radically change your midlife experience, and so much more. This is part 2 of our favourite moments from the world's most renowned experts. If you've missed part 1, start there. But if you're ready for real talk, powerful insights, and the support you deserve, you're in the right place. Let's get into it. I want to ask you a little bit about the brain and depression and anxiety. My very second podcast had Professor Jayashri Kulkarni, who I know you're speaking with at the Opera House on Saturday. And she is just this amazing psychiatrist who's really been championing how much estrogen is really should be at the forefront of the care of women, not only with menopausal, but probably even in postnatal depression. Like if you
Yeah.
kind of think about it,
Yeah,
again, why did I never think about it going, I never thought of that.
Yeah.
Tell me what you see with your patients mood-wise with perimenopause and menopause.
The anxiety is crippling in perimenopause, and it's usually the thing that will bring them into my office the fastest. With the cycle irregularity, they'll go to the gynecologist immediately, and that was my job for a long time. But now that I just do menopause care, they've usually seen 2 or 3 clinicians. They've been gaslit, or they're on some cocktail of SSRIs, right? And they may not be doing well. Well, the data coming out of Australia is very clear that in perimenopause, new or worsening, first line should be menopause hormone therapy. And I am seeing it work miracles in my patients for mental health. So both depression and anxiety related disorders. Now, postmenopause, that's not the case. She has a new onset postmenopause. The data looks like at SSRI is probably the best place to start, and menopause hormone therapy can be adjunctive to that. But in peri, absolutely give her hormones, stabilize that brain, because our neurotransmitters are heavily dependent on estradiol levels. And not just estradiol levels at baseline, but limiting the fluctuations. The brain hates that chaos, hates that fluctuation. If we can calm her down with low-dose estrogen, usually in the form of a patch, so you really get a steady state, then they are doing so beautifully.
And is there any connection between the severity of your brain fog or your brain symptoms and then further cognitive decline later?
So no, thank God, no. And most women will have a rebound period and go back to some level of functioning, maybe not exactly where she was before with cognition. So the brain fog starts in perimenopause, and really like right before the period stops seems to be the worst. And in the US, we're losing at least 1 in 10 women to their jobs. They're leaving their jobs because they don't feel like they are can complete their tasks or that they've always been able to do. And in the UK, it's as high as 1 in 5. So huge effect on the workforce. And then, this new ADHD, this new inability to
that
task manage.
ADHD.
And so we are seeing this kind of uncovered where she was able to manage and had built her life around her ability to manage symptoms, and that gets taken away.
Yeah, it is unbelievable. I just want to ask about what your hopes are for the future of medical school and I suppose just medical training so that we can make things different.
So there's no recognized curriculum for menopause education. We don't have that. And so what I would like to see worldwide is that in all clinical education, medical clinical education, so medical school for physicians, for our nurse practitioners, in the US, we have different levels, and I'm not sure what you guys have here, but we have physician assistants, we have nurse practitioners who see patients as well. That this is just a normal part of their training. They learn this happens to men, this happens to women. Here's how, the two genders react differently, especially with aging and when she loses the production of estrogen and progesterone from her ovaries. This is what we need to address and understand in each organ system and how it's affected. That would be my dream. My other dream is that it's not a big deal. Every woman knows it's coming. It's like puberty. You have your girlfriends. Like I was with at the Oprah thing. I was with Halle Berry. Sorry, menopause brain for a second. Halle Berry sitting on the couch next to her, and she was talking about why don't we have menopause parties? Like we have divorce parties and wedding showers and puberty girl. Period starts and the moms get all excited and do all this stuff. Like when we know it is the end of our cycles and we're in this last third of our life, which I think should be the best third of your life, because it is for me, that should be a celebration, right? This wonderful thing. Look at us. We get to lean into our wisdom, and that she can walk into her clinician's office confidently and have an informed conversation about her menopause and how she wants to manage it and go on about her life. The end. I mean, I don't think every woman should have hormone therapy, but I think she deserves the option.
Yeah, absolutely. And what's the biggest misconception you think people have about the menopause?
That it's somehow the end. This is like, I'm 56. I'll be 57 in August. And I'm about to outlive all three of my brothers that died. I'm about to like pass that milestone. So I've had six brothers and I've lost three to two to cancer and one to HIV and hepatitis. And I'm about to be older than they ever were, all three of them. And so life to me is a gift. But I am living my best life right now. I don't want to be 45 again. I don't want to be 35. I don't want to be 20. I love my life. I have better relationships. I'm a better business person. I have better patient care. I'm teaching women by the millions. I'm part of this incredible revolution. I've got, had I not addressed my menopause and just accepted the status quo, I would not be here today. And I want every woman to wake up at 56 and feel the same way I do. And that's not happening.
We haven't talked at all about testosterone. Can you give me just a very quick...
I'm a fan. So, gosh, for my patients who have a great relationship, used to have a good libido, don't have pain, can orgasm, all the plumbing's working, all the once they get going, they feel okay about it, but it's the whole like the desire, the drive to do it. And they used to have a good drive. Testosterone is miraculous for them. They feel that drive for intimacy again. They feel, especially when their partners come with them to the visit who are supportive. Um, it is really a beautiful thing to watch that intimacy be rekindled by giving her back testosterone. Now, I've used it now in hundreds and hundreds of patients. And yes, they are seeing an uptick in their libido. And I'm not talking chandeliers. You're not 25, again. I've also seen women get the courage to leave a relationship that wasn't serving them. There's something magical about menopause when you circle the wagons around yourself and you're able to put up boundaries and say no to things that because you're in survival mode. And so it can be a really positive thing. But, for patients, I'm using it off label. If my patients are coming in and I have a muscle mass scanner, right? And they have low muscle mass and they are heading towards a path of sarcopenia and possible osteoporosis, I'm recommending testosterone in very low physiologic levels, female physiologic levels, to help them improve their muscle mass as long as they eat the protein and do the resistance training. I don't think it's magic, right? The testosterone, the creatine.
You're
I'd
not
love
gonna
to
have you're not
see.
gonna have Popeye arms at the end.
No, God, no. But it's like you just want to be able to get off the toilet without help. Right? And lift a grandbaby and climb a mountain or whatever you want to do, but you deserve that. And I feel like in those cases for testosterone, it can be really, really helpful for patients. Now, some are saying that they have improved stamina. Some say it improved mood. We don't have enough research to say clearly all women will benefit in those ways. But in my patient population, I'm seeing a lot of positivity around getting her back up in that 60, 70 range of her testosterone.
And do you find, though, that I find when I prescribe testosterone, it does take a little bit longer to see a result than maybe something like estrogen can
Right.
work really
Estrogen, yeah,
quickly?
3 to 4 weeks for hot flash resort. You bind the thermoregulatory center. It's almost, it's just really quick. But testosterone, again, libido is tough, and it's like
Oh, it's so
I
complicated.
say that it's a flight deck of a 747, like the males is like a light switch, doop, doop. And then ours is so complicated. So like to give themselves grace and to, especially if they're also having vaginal atrophy, we need weeks to allow that tissue to heal before even attempting anything again. But yeah, and then, we are checking levels to make sure we're not overshooting our therapeutic windows or undershooting because, we all have different absorption rates in the skin. We're seeing that with the estrogen patches. Brilliant work from Louise Newsom,
Yes.
and her team in the UK looking at different absorption rates of the transdermal estrogen preparations. Because of that study, it has changed my practice where I was just titrating the hot flashes, but we are a lot quicker to check doses, to check blood levels for estradiol after beginning therapy, to make sure she's absorbing well. About 20% of women seem to be poor absorbers, and I was one of them.
Interesting.
Yeah.
And what about vaginal
I think
hormones?
100% of women should be on vaginal estrogen.
And both? You do if
Oh,
someone
yeah,
calls,
absolutely.
yes,
You can
yes.
have both. Remember, it's like cortisone cream. I mean, literally, it's a whole tube of one pill of oral estradiol, 2 milligram pill would basically be multiple tubes of vaginal estrogen. So that's like it's
Tiny
so it's such a tiny, tiny dose. And so I'm using it prophylactically with my patients. I'm not waiting until their tissues become inflamed and irritated and thin and they're having pain. Why would I do that to her? Vaginal estrogen is safe for everyone. Even with an active breast cancer, you can give her vaginal estrogen. You can absolutely save her marriage and her life and keep her out of the ER with UTIs and recurrent sepsis. I mean, so in Rachel Rubin in the US, they did a study looking at if we went into the nursing homes and did vaginal estrogen in all the nursing home patients, how many cases of sepsis would we avoid? And they think it's 50%. And how many billions of dollars of Medicare would that save with all of these recurrent admissions for UTIs and urine sepsis?
People then get delirium and then,
Yeah, yeah. I mean, so whenever I post something like that, all of my followers who work in nursing homes, like they go crazy. They're like, "Oh my God." And they talk about these poor women who are just suffering horribly without, and we could just help so much by giving everyone vaginal estrogen because 100% of us will get GSM. 100%.
And it's the same here as in the US. We've got this terrible leaflet inside.
Oh, yeah, that it will kill you and cause a stroke, and none of that is true. So, Jennifer Weisswolf from New York, she's an NYU attorney, she a law professor, really, and so she and I co-authored the Citizens Guide to Menopause Advocacy, very similar to what you guys put together in Australia when you got the $500 million. I mean, I'm like, "Ooh, please, God," here in the US, but things are a little sketchy with I don't know what's gonna happen. I don't wanna be negative. I'm gonna focus on results and not problems. And so number one was mandatory education in our clinical programs. Number two was remove the black box warning from vaginal estrogen for God's sake. It's ridiculous.
Sometimes I have a very long menopause consult. It's 1 hour long, and yet I still manage to fill the whole time. And occasionally I forget to mention, don't look at the little leaflet.
Leaflet.
I just trust me, I'm not going to put you wrong. And then they come back and they go,
Oh.
I didn't start that because I was a bit worried. And I'm like, no, please take the vaginal hormones. We've had a few questions where people are asking, what actually is the point of women having a menopause? Is there like an evolutionary benefit to this thing?
Yeah, no, it's a super interesting question. And I dove into it because my second book, which is way more about menopause and hormone therapy, is coming out later this year in September, I believe. And so I looked into it because one of the things that people talk about is like, people use it as a justification, I think, to not take hormones because they think that there must be some sort of evolutionary benefit to living without hormones. And no, not that we can think of. And the other big myth that I love to dispel is people will always say humans and 4 whales are the only people to go through menopause. First of all, menopause means no periods in 1 year. Most mammals don't have periods. Most mammals self-resorb their uterine lining. They don't bleed, right? So you can't really say other animals have menopause or not because they have different bodies and uteruses than we do. Okay, so there's that. If you take mammals and you have them live in captivity, which means clean water, no predators, antibiotics when they get sick, right? If you take care of them, they all live longer than their ability to reproduce, which we're going to use that as a marker for menopause because they don't bleed, right? So, okay, well, we're well preserved. I actually wanted to name my second book Living in Captivity because we are being well preserved now, right? Antibiotics alone have extended the average life expectancy by 26 years. It's crazy. And we don't think, because we are living now and not before, we don't think of the fact that we are aging as a population longer than we ever have. And that's brand new, right? Like we're just figuring out how to do this. And that's why I think Gen X is so powerful, because we're seeing people do it poorly. And we're like, what if there's a different way? What if we can prevent frailty in the first place? What if we can prevent heart disease, prevent osteoporosis, prevent dementia? And in order to do that, you have to preserve the body a little bit better. So this whole like evolutionarily benefit, yes, in the fact that from yeast species to fruit flies to like all species that reproduce, there seems to be an evolutionarily benefit to living longer than you can reproduce. Reproducing is very expensive as far as resources go. So all of these species will live a little bit longer than their ability to reproduce. We don't call it menopause. Fruit flies don't go through menopause, but they live a little bit longer. You take the fruit flies and you put them in captivity, and they live exceptionally longer, right? So I think of humans as we're humans in captivity. Now we have the ability via sanitation, clean water, antibiotics, trauma surgery, exceptional cancer care. We have the ability to live 40 years past our reproductive ability. And that's where the frailty comes in, because the hormones work everywhere in our body, not just reproduction. So I think when people oversimplify it and they're like, menopause is God's gift to humanity because now we can take care of the grandbabies and not worry about being pregnant. I think we're not understanding actually how our bodies work, and the fact that we're kind of fake in living to 90 as a population, but we all want to do it, right? So it's like, if you wanted to truly be natural, we wouldn't be living that long. If you look at Victorian England, where they kept track of the wealthiest men for death records, right? Because nobody else, paper was expensive. They weren't keeping track of people that weren't important. The most important people, they kept track of birth and death records. Average age of death for men, the wealthiest men, was 47. And there are some data in women where they had babies into their early 50s, death was 57. So this whole like, is it natural to not take hormones after menopause because it was meant to be? I would argue living to 84, which is our average age of life expectancy in developed countries, that's not natural. But we all want to do it, so let's do it well.
Agreed. And what about the people who say, well, HRT isn't a natural thing. I'm just going to let my body do it naturally.
Yep.
I mean, can you just extend that a little bit further and talk to the fact that we are using hormones ultimately that are pretty identical to what our body makes?
Yeah, and I'll even take it one step further. The social psychologists have researched this myth of natural, or what they call the naturalistic fallacy. And what that is the belief that if something is natural, it's therefore superior, or it's therefore better, or it's therefore the just and right thing to do. And that's just a thought error, right? It's like anthrax is natural, you know, drinking water that has feces in it is natural in nature, right? So it's like, natural isn't this utopian Mother Nature pristine environment. We have trauma surgery because falling and breaking a hip might be natural, right? So it's this, I like to just say, yes, the hormones we use now are exactly what our body makes. And check your bias. If you're living your life by only doing things that are natural, why do you have on shoes? Why do you put on sunscreen? Why do you get dental care, right? It's all unnatural when you start picking at it. And so you can you can open people's eyes to their bias, because again, we use that naturalistic fallacy to withhold care. I believe withhold preventative medicine from people's bodies.
Well, even the word natural is used, for example, in the world I am in, which is skincare.
Mhm.
And lots of people will put the word natural on skincare and it improves sales. So clearly there is like a subconscious bias that people, gravitate towards a product that says something. But what is the definition of natural? You can't define it. It doesn't actually mean anything.
Yeah.
So lots of patients will say, "Oh, I like to use natural skincare," but what does that even mean?
Yeah.
So it's definitely a word that has a very emotive thing for people in very many realms.
Yeah, I mean, it ties into purity culture, right? It ties into all like what you should do. And it kind of takes away the ability to think critically about things because you're kind of putting pressure of doing it right by this belief, again, in the naturalistic fallacy. So I like to point that out. Like, yeah, we've researched people's like belief in this, and that's what we're all doing. It's say you can put natural on a candy bar and charge more money for it. And that word natural in the health foods world actually is meaningless. It's less meaningless. Like the word organic is more defined.
Yeah.
The word natural is actually meaningless. It's marketing.
It was interesting when I did my little piece where I went into this street and talked to people and asked them, their thoughts on hormones and their thoughts on menopause and things. There were a number of women who said, "Oh no, I just think I just want to do menopause naturally,"
Mhm.
and I nearly feel like it becomes like a badge of honor to do it naturally.
Mhm.
And, I just wonder how we've got to that point where women feel that that is actually the superior choice whenever the data and the research clearly shows us that it's not, in
Yeah.
terms of not only longevity, but living well for longer, living healthier from your bones, from your heart, from your bladder. Everything is probably going to be improved
Mhm.
by taking hormones. And yet people seem to feel like, I don't know, there's like nearly like this, that makes them, I don't know, that it proves they're more resilient or something by not taking
Yeah.
hormones.
I mean, to me, it's lack of education. When I hear a woman say that, I think, does she know what menopause is? Because the video you did was so insightful, is like going back to the basics of do you know what menopause is? I mean, the definition of, again, of menopause is 1 year with no natural periods, but it's actually a profound hypogonadism. It's a profound decrease in the function of the ovaries. And once women start understanding that this is like a man's testicles stopping working. We never tell a man who has low testosterone in his 40s, 50s, and 60s that that's natural. Erectile dysfunction is natural, and Viagra is one of the top selling drugs in the entire world. So the other thing I like to do is hold up the lens and say, okay, fine. If women should do it natural, let's apply it to men as well. And then we say, "Oh, we treat their issues associated with aging. We treat their low testosterone. We treat their erectile dysfunction. We treat all of these things in them, so why aren't we doing it in women?" And so it's like I love holding up because ultimately, I don't care if people take hormones or not. Me and the other advocates out there, it's like your body, your choice, but your body, your choice with education. Understand what's happening, and then you choose.
Kelly, I'd love actually for you to talk to us a little bit about testosterone and low testosterone in men, because I know that as a urologist, you look after both. How does that present? And does it present in a similar manner to some of the symptoms we see in women with low hormone levels?
Yeah, actually, it pretty much does. So, the most dramatic way to see a man deal with low testosterone is prostate cancer treatment. So, we actually give them medication that drops their testosterone really low. Those men say, I'm lethargic, I'm tired, I have no more get up and go. There's no libido. I'm gaining weight around the middle. I'm losing my muscle. I don't even want to go to the gym. And then hot flashes, really bad hot flashes. And those men are some of the most sympathetic men towards what menopause is. They're like, that's when you take your hormones and you drop them. And same with women. That's where you take your hormones and you drop them. One of the problems I think with low testosterone or and low hormones is like these hormones are in every cell in your body. So it can look different in everybody. If you're like, what does a broken arm look like? That's very clear in all humans. A broken arm looks like a broken arm. But for you, it might be, well, your hormones are affecting your brain more. This other person's hormones are affecting their heart more, right? So it presents different, and that can be vague for some people. And the symptoms of low testosterone can be vague, like decreased energy, decreased mood, decreased muscle mass, right? It presents differently in everybody. It doesn't mean we shouldn't treat it. It just means we're all individuals, and it's not as cut and dry as like if you have a piece of wood in your eye, everybody presents the same way with that.
And in terms of, so I don't know if it's the same in the US. There's definitely in the last sort of, I would say 2 to 3 years, been a real interest among young men older men about testosterone levels, what their testosterone, like I have to say, in the previous sort of 20 years of my career, I'd really never had anyone as a male present asking for testosterone levels. And then suddenly in the last 2 years, lots of men asking for me to check their testosterone levels. Do you know where that's come from? And is that something that as doctors we should be doing a lot more regularly than we do?
Have you ever heard, I'm going to answer your question legitimately, but have you ever heard a man say, I'm just going to deal with my low testosterone naturally?
No, I have not, to be fair. They come and they tell me, "Oh, I want to have my testosterone checked because my friend who I go to the gym with had his checked and it was low and blah blah blah. And I want you to check it and replace it." Yeah, no
So
one's talking about doing it.
nobody's talking about doing it naturally, right? So it's fun to hold that mirror up to be like, women, what are you doing? When men are suffering, they know that there's solutions. They know it's okay to be treated. They know they're going to feel better and they know that it's safe. Right? So it's like, I want to get that into the women's head too of like, yeah, it's the same stuff, like low hormones, low hormones. But no man's like, I think I'll just like learn how to breathe more deeply.
Go and do some Pilates for
Right.
your low testosterone.
Exactly. Like exercise is fantastic, but it will not replace gonadal function. So the testosterone in men, it's been growing in America for quite a while. The exciting news about testosterone in America is March 1st, the FDA just announced they're going to take off the cardiovascular risk from the box warning, which is fantastic because one big myth of testosterone is that it might be dangerous or it might increase your cholesterol or it might increase your cardiovascular risk. That has not been shown to be true. So the fact that the FDA is correcting misinformation on testosterone, I'm very excited because they need to correct the misinformation on vaginal estrogen, and I'm hoping that they will do that. But again, I think it goes back to men want to feel good. They want to be optimized. They have in the male culture, it's like to be fit, to be vital, to have a healthy sex life that is normalized, appreciated, and supported. That's not always true in the women's health domain.
And is there a danger from having too high a testosterone or taking too much testosterone as a male?
Yeah, I mean, I think it's a fun myth because even though women who are on hormones, they'll be like, give me more, but give me more. This myth that like more is better, right? Whereas in medicine, it's like if the blood pressure medication's working, you don't give more, right? If your insulin's controlling your diabetes, you don't give more, right? So there is like supraphysiologic, meaning giving more doses than your body naturally deals with. A little bit's okay for some people, but to a point, you're going to start getting side effects. Just like if you give, coffee's good, more is not always better, right? Like there is a point where you can have too much. And we see that in the testosterone world. I see that in women who are on hormones. They think more, 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 more. Or they think hormones might be a cure for everything. They are not.
One thing that I hear repeatedly from all my new patients is that often their past experiences with appointments to address their symptoms of menopause have made them feel rushed, unheard, and frustrated. As a doctor of 25 years with first-hand experience and understanding the many symptoms that one woman may encounter in her menopause transition, I knew I couldn't do this subject justice in a 15-minute appointment. Which is why I've created the Menopause Appointments, designed to support you on your journey through the perimenopause and postmenopause. This 60-minute session gives you and your doctor the ideal amount of time to understand your concerns, needs, and desires. It gives us time to do a comprehensive assessment, including a full review of your medical history, assessing your mood, your sleep, weight, and libido, and much more. Receive referrals for tests as needed, prescribe suitable medications if required, perform a skin analysis, and leave you with a comprehensive tailored plan unique to you. This is crafted to help smooth your transition through the perimenopause, postmenopause, and allow you to thrive, not just survive. If you or someone you know is experiencing perimenopause or continuing to have symptoms in the postmenopause, these appointments are for you. You can book an appointment with one of our doctors today. We have clinics located at Forster Speech and Newcastle, and you can book online at youbydrshaunaWatts.com.au.
Even though I'm going to tell you how I want people to recompose their bodies, I recognize that nobody can jump to that. And I don't want people just to start when they're 50. I have millennial daughters. Actually, they're what comes below Gen Z? I have Gen Z daughters. I have a millennial daughter. I need them to be putting down bone and muscle. And I talk about it all the time. If they do not know it, it is not because I am not preaching to them, because that is when we build our storehouses that from which we use, right? So what do I want midlife women to do now? Number one, you must eat an anti-inflammatory diet that's focused on 1 gram of protein per ideal pound a day. And it's doable. It takes some tracking. It is achievable with whole foods as well as protein supplement, high quality protein that contains adequate leucine. So that's number one. Number two, in that anti-inflammatory diet, we are not going to eat sugar. We are not eating added sugar. We are not eating white, simple carbs. It doesn't mean we're not eating carbs. We're eating fiber carbs, so you get 30 grams of protein a day. And it just is a shift. For instance, when my family wants to eat white potatoes, I am baking a sweet potato or yam, not with sugar and molasses, but just baking it because it's so fibrous if we're going to eat that kind of starch. So protein, complex carbs, absolutely no sugar, and the rest green leafy vegetables. So there's a lot more to an anti-inflammatory diet, but those are the easy things. People can only do a few things at a time. So that's number one. Number two, we have to lift heavy. So we have to provide the proper stimulus to our muscles that they'll actually build muscle fibers. If you lift a mamby-pamby pink weight 30 times and it causes no stress to your muscles, you're not going to gain any hypertrophy. You're not going to gain any power. So heavy lifting is, and I'm trying to make it simple. There's a range, but I've made it simple for my people. 4 reps, 4 sets of the compound power lifts, which is push, pull with your arms, push, pull with your legs, 4 times 4, which means you have to go pretty heavy if you can only do it 4 times. For the accessory lifts that support a compound lift, like let's take bench press. Bench press is a compound lift. The things that support it, biceps, triceps, lats, delts, rows, 8 reps times 4 sets. And that is kind of the pattern for lifting heavy. Now, we add to that, I have added foot speed and agility to that, because it's one thing to be strong enough to hold yourself up. It's another thing to have the foot speed and agility not to trip and fall down, because we die of femur fractures, sometimes because our bones are so brittle they break and then we fall. But most of the time we fall and then we break. So we need to build some fast twitch and agility muscles back. And there's simple exercises we do with that so that we can stand upright. So anti-inflammatory diet, lifting heavy plus speed and agility. And then number 3 is, what are we going to do about our heart, right? We need great cardiovascular health as well as power and strength. To build cardiovascular health, we need to do 3 hours a week of base training, which is basically brisk walking, or 45 minutes of brisk walking every day, which is not that long. Twice a week, we need to speed it up and do sprint intervals, because that is heavy enough work that then causes things like our mitochondria to replicate, all the good, yummy things we need to do. So sprinting is not like we're seeing in the Olympic trials right now. Don't worry. People get freaked out when I say sprinting. Sprinting is a heart rate measure, getting your heart rate up as high as it can go for 30 seconds, followed by complete recovery. So when I sprint for 30 seconds, I then turn the treadmill down and it takes me a couple minutes to recover. And you only do that 4 times, 30 seconds times 4. So those 3 things. Then if you want to get really advanced, you layer on VO2 max training, because that's a whole different subject. But not everybody can do these things because they've stepped away from the couch for the first time. So if you eat high protein, if you walk every day, and if you do body weight exercises, you can still lose weight. You can still recompose your body. And if you do that for a couple months until you feel comfortable, then you move up to the regimen I just talked about.
I actually had a listener ask me a question to ask you about these weighted vests that you can use for exercising. So they wanted me to know what you thought of those. And she said, what's the difference between wearing a weighted vest and then being told that carrying excess weight on your own body is bad for your joints? So I thought that was just an interesting question.
It is an interesting question. Well, yes and yes. True and true, right? So we know that heavy people have less osteoporosis than skinny, fragile people. We know that because they carry around all this extra weight. So the way to understand whether you need a weighted vest or not is to get your bone density checked, right? And if you have osteopenia and need every possible mechanism to build better bone, well, that could be an option for you. But the question is valid because we know joints bear 7 to 10 times body weight. And so when you're really heavy, that is one of the contributors to progression of arthritis. So true and true.
Amazing. Thank you so much. So we've talked a little bit about osteoporosis and osteoclasts and osteoblasts. So when do you think people should have their first DEXA scan so they know where they are with their bones in an ideal world?
I do, because I call 40-ish, whether you're 35 or 45, 40-ish, the critical decade for getting your proverbial, I could swear, but I don't know you well enough, together, right? You've got to get it together. It's time to adult. It's time to have a life insurance plan. It's time to have a will. It's time to have saved enough money so you're not starving. And it's time to start caring about your health. And so just like you need your first true physical, if you haven't gotten it before, you get your mammogram. I think you need a bone density because I have so many women showing up in my clinic in their 30s with fractures because they never laid down enough bone. Because we have had, in the United States, we've had this law called Title IX, which equalized sports participation across all educational levels. So for instance, I don't know if it exists in Australia, but if you have 50 boys playing high school sports in one school, you must have 50 girls or equal sports. So just to equalize play. Well, because of that, we have a huge generation of women who were athletes their whole lives. And sometimes athletes are amenorrhea, meaning they don't have periods for years because they live in a constant state of relative energy deficiency. And so they never lay down enough muscle. They never lay down enough bone. And so they arrive at 30 when they're supposed to have peak bone density, osteopenic. And so I think in this critical decade to get your proverbial shit together, you must get a DEXA scan, even if it's not paid for. Save your Starbucks money because, we can get them here. I don't know what they are in Australia. We can get them here for $99 at a gym. Some gyms have clinical DEXA scanners. And I don't buy the excuse that, insurance doesn't pay for it until you're 65. You must not need it. No, there's a difference between health prevention and disease care. At 65, you are going to be caring for disease. You're not going to be preventing disease.
And that's so interesting to me because I'm a family physician and I definitely see a lot of young female athletes and also a lot of dancers who are struggling with recurrent stress fractures and things like that. And so I know that's sort of slightly off topic, but do you think that they should be having DEXA scans?
There are many universities in the U.S. now that do DEXA scans on all incoming freshmen and as the athletes progress. Now, do they do anything with that data? That's another question. But they do it. And the chairman of orthopedics at the University of Wisconsin her entire life's research has been on bone density in female athletes. And what her work finds is that the impact sports like gymnastics have much better bone density than the non-impact sports like swimming. And that's not surprising, but she has documented that.
That's so interesting. I've got a ballerina as one of my children, so we seem to just stumble along from one injury to the next, it would seem. In terms of osteoporosis, what do we know about what HRT brings to the table? If someone already has established osteoporosis, is there any way of turning the clock back or improving that?
So I encourage, we know for sure, I mean, there's irrefutable data that estrogen can prevent osteoporosis or prevent osteoporosis. We know that. Can it reverse osteoporosis? Well, I think it should be part of the toolbox because remember, it controls the osteoclasts. The osteoclast, as I illustrated, it controls its runaway activity. You're never going to get in front of a destructive process to try to build. The osteoblast is never going to catch up. So we have to dampen the effect of the osteoclast and rather do it with estrogen than a pharmaceutical drug. So that's number one. It must be part of the toolbox, of the roadmap. In addition to eating enough protein, knowing your vitamin K, supplementing if you need with some potassium, taking your magnesium. You know, there's some weird supplements out there that I don't really know the data on, but boron and zinc come up sometimes. But the three you must be solid on. You must eat enough protein. Estrogen will stop the imbalance. You must lift weights. There is a study called the Lift More study that shows that even women with frank osteoporosis, when lifting in a controlled way, can do it safely, can lift heavy safely. And so I encourage all my women, even with osteoporosis, to lift heavy safely. And then walking plus or minus with your weighted vest. All of those things will add up. And then if you are still frankly osteoporotic and at risk for fracture, that's when we pull out the armamentarium of drugs. And there are very many that either maintain bone density or can rebuild bone density. And most women don't want to go on those because of the side effects. But if it's a choice between building bone back and dying of frailty, where we know if you break your hip, there's a 30% chance you're going to die, I think you need to not make that decision flippantly.
Yeah, absolutely. And in terms of supplementation, what are your thoughts on calcium supplements and vitamin D? Obviously, here in Australia, we have skin cancer and melanoma rates that are absolutely off the chart. When I first moved here from Belfast in Northern Ireland, I actually just could not believe how much skin cancer I was seeing. So we're always preaching factor 50 plus all the time in terms of SPF. And then we, of course, do see people with vitamin D deficiency. Do you have any thoughts on people taking calcium and vitamin D?
I have lots of thoughts. I would rather you get your calcium from your food and not as a supplement form, almost across the board. If you're eating a healthy, anti-inflammatory diet filled with green leafy vegetables, you're likely to get enough calcium. Although if you don't, you can always supplement 1,200, 1,800 milligrams a day, but I'd rather you get it from food. So I rarely recommend calcium supplements. Vitamin D, you need to have it measured, and the units are different in every country, but you need to have it measured. If you fall into deficit, you need to aggressively replenish it. When I first measured mine, it was barely perceptible because I'm a SPF my whole life person, except when I nearly burned my skin off when I was 16. Since then, I've been an SPF. So it was barely perceptible. And so for a while, I was taking 10,000 international units a day to catch up. And then after you catch up, you can have a maintenance dose.
So, Corinne, what I'd like to ask you is, what is the current thinking for women who've had breast cancer and gone through all their treatments, and then perhaps are then having a lot of symptoms? What is the thinking around them taking HRT? And obviously, I know it's a very nuanced and individual discussion, but you know, there used to be this absolute no, you've had breast cancer, that's it, you're never allowed HRT. What is the thinking currently?
Well, I think, listen, what most women experience is still total roadblock and not even an intelligent, informed decision or even an ability to even have a conversation. They're just like, no, I'm not talking about this. No, no, no. I mean, that's really what most patients get. But it's interesting. I just actually downloaded the Menopause Society here in North America, their updated 2024 slides, literally just this morning. And I was really pleased to see that they're now making official references, and they've had it in their position statement for a while, as had the British Menopause Society. That does make it more nuanced, saying that, listen, we've got, insufficient data and not perfect data on the use of hormone therapy after breast cancer, right? We've got a lot of observational data, over, 25 published studies over the last few decades, many of which are smaller sample size. They didn't follow them for huge amounts of years, but showed no increased risk of recurrence or death. We do have one study, the Habits trial, which was insufficiently powered and was stopped short, that showed an increased risk of a local recurrence or a new primary, but not a distant recurrence or mortality. And that was a randomized study that, again, was stopped early. And at the same time, there was another randomized study called the Stockholm trial. These are the big ones that people talk about. So that's why I mentioned that showed the opposite, that showed there was no increased risk. And they followed those women, even though they stopped it early. They followed them at 4 years, 8 years, and 10 years and saw that those results held. And that's what's supported by a lot of our retrospective reviews and our observational studies. But what I'd say is the data's not perfect. There's a lot of holes in the data. And so it leaves people really uneasy, right? When we look at subsequent meta-analysis of the available data, what's interesting is, when you really sit down and look at it, most of the meta-analysis basically report that the overwhelming evidence does not suggest that there's an increased risk of recurrence. When they look at receptor statuses, in the studies where they were able to find, because some of these studies were old, whether they reported an ERP or positive, they do note that with women who are estrogen receptor negative, that there is no data points out there that showed that there's any increased risk of, breast cancer recurrence, once these women were properly treated, compared to women who have not used hormone therapy. And so I'm seeing a little bit of an opening now, and that's what I saw in the menopause slide deck that they just released, that they actually have an official kind of wording there that after 5 years of being disease-free for estrogen receptor negative patients, because we know for ER negative patients, they're most likely going to recur in the first 2 to 5 years. Once they're out of that 5-year window, their recurrence risk, stays low, that it can be considered in them. And then for ER positive patients, frankly, and this is kind of I think a nuanced wording, but people don't actually read the position statements. They just have knee-jerk reactions. They say, if a woman who is completed her breast cancer treatment, her non-hormonal options have not worked for her, she wants to have a discussion, it should be an individualized, nuanced discussion with her oncology team. And so that's, I think, how it's moving a bit, but it takes a long time to change doctors' minds, right? And I would say in my experience, most breast cancer survivors are not even seeking HRT, right? They're not. But for the ones that are, they're often very motivated. They are very knowledgeable. They've tried it all. They've tried the non-hormonal stuff and the lifestyle things. For those who have not, we always try to start with the big toolbox of how can we help you? And a lot of times there are a lot of ways that we can help patients with their concerns, not only symptoms, but also things like heart disease and, osteoporosis and bone health. There's many strategies here. But listen, there's a proportion of patients who are just like, I get it. I have an extremely low risk of recurrence, and this is my quality of life. And I either was on it before and I felt so much better that I know I'd like to go back on it, or I've suffered for this long and I'm done. Like I choose this. And I have many women say, I would rather a better quality of life, and I'm willing to take that risk. But the problem is I feel like that option of who gets to decide that patient's autonomy for her body,
as a cancer survivor is taken away from her. She's not given the choice. She's not even given a discussion. And if she chooses it, I see patients getting fired by their oncologists. Today, one of my friends and colleagues, she wrote to me because I referred her a patient who I wasn't licensed in her state, so I sent her way. Early stage breast cancer patient, very well informed, treated, very, very low risk of recurrence, really suffering and really wanted to have low dose estrogen and little progesterone. And so she started on progesterone only. And then just recently, she was doing great and sleeping. And just recently, she started on like the lowest dose patch. And it's really, really helped her. She saw her internist. Her internist didn't say much at the appointment. And then the next week, she got a letter saying, "You've been expelled from the practice. You need to seek someone else because you're not following evidence-based medicine." And they fired the patient for the practice. I see that with some of my patients too, where their oncologists are like, "Well, if you're going to do this, you got to find some other doctor." And I am like, and it happens more than you think. And I find it interesting because I don't see many doctors firing diabetics who aren't exercising and eating well, or firing their hypertensives or cardiac patients who maybe aren't doing, the right things with their medications. But we feel it's okay to fire a woman who's made like a really informed, educated decision and is caring about her quality of life and her bone health and other things. I mean, how is that sane?
Yeah, it's absolutely crazy. Corinne, what do you think the unique challenges are of the younger female going through an early menopause? Do you think that they have slightly different symptoms or they present differently?
They do. I mean, so the data is really clear that regardless of the cause, whether it's breast cancer or not, although I would argue whenever cancer is in the equation, there's just such a heightened stress and other concerns going on that it just makes everything worse. But remember, these younger women, not only obviously fertility concerns, but we know their symptoms tend to be worse. Like, and I know you didn't have hot flashes, but you sound like you had a lot of other things, right? But tends, when it's abrupt and when it's younger, the hot flashes, the vasomotor symptoms tend to last longer or more severe. So the earlier they come, the stronger they are. The data shows the longer they last. Um, and so their impacts on their quality of life is worse. And I think that their impacts on their sexual health and their relationships, and I don't want to minimize it, that's not a problem for older women. But when you got young women who are either in relationships or still in the dating world or, navigating marriage, when you rip away her sexuality by taking away her hormones and not addressing it in any other way, that's really impactful. These women with early menopause, they're also in the midst of often either like they're climbing the corporate ladder, they're in the middle of their careers. And so all of their symptoms really negatively impacts them kind of financially and in their career. Um, they have a much higher risks of mental health issues due to the complicated nature of their menopause. And so this is why I always say these women have the most to lose and the most to gain, if we could help them. And what makes me really sad is that even for the women who we don't recommend systemic estrogen therapy for, right? Not all breast cancer survivors would we recommend it for, but we don't even offer them like vaginal estrogen. And that's what really makes me super angry. So I always come back to that. I'm like, please at least get that, right? Um, and so, yeah, they really need to be elevated and treated with, the urgent needs that they have. And they need to be thought of holistically because these women, early stage breast cancer incorporates stage 1, stage 2, and stage 3. That's all technically early. Most of these women survive their disease, right? Most early stage breast cancer patients do not die of breast cancer. They die of heart disease. They die of hip fractures down the road. They might lead a life of diminished health span, right? And who gets to decide how they manage those risks? It's quite a challenge. And I don't want to harp on only cancer. I think there's a lot of premature menopause out there that's not cancer related. Those women are as poorly treated as the cancer survivors.
I've heard you talk about sleep hygiene.
What is sleep hygiene and how can women improve their sleep hygiene?
So, yeah, sleep hygiene, it's always a funny thing. I always remember even at medical school when they introduced the concept of sleep hygiene, I always thought it was the weirdest phrase it's really looking at the habits and the environment that you place um around your sleep routines. And I suppose in simple terms, it's how you're going to clean up your routine to make it as conducive to a sleep environment. So I think whenever we think of sleep hygiene for any person, but especially, someone in perimenopause or menopause, so the first thing would be that obviously we know that there's something wrong with that sort of heat sensor in the brain. And often for some women, it's just running hot, like I did. And for other women, it is that overwhelming flushes or night sweats. So the first thing is to keep your bedroom quite cool. You definitely don't want to be overheating. So keeping your bedroom probably a couple of degrees cooler than you think you want it to be. And the other reason for that is we actually know the human body needs to drop about half to 1 degree to actually fall asleep. And that's why it's so hard to go to sleep on a really hot night, because you just can't get that temperature drop. So I think keeping your room cool. I also think that having your room your bedroom as an environment that is actually conducive to sleep is really helpful. So, having, all those unpaid bills laid across your bedroom floor, or maybe having all the black bin bags that you've cleared out your wardrobe 2 weeks before and not getting rid of them. So I think it's just, being sensible about trying to make the environment really nice. I think, we know that darkness helps. And, I'm very, very guilty of this one. But, it's not having that light from your phone or your iPad. So it's very tempting to lie in bed and look at your phone and scroll and things. And there's multiple reasons why that's not helpful. One, it's very activating to the brain. So you're kind of waking yourself up. But it's also the light is confusing the brain, because we want melatonin to be released to tell our body it's dark, it's time to go to sleep. But then we're shining this bright light. And so our body's going, oh, hold on, actually, maybe it's not nighttime. So let's turn that melatonin off. So I think darkness, coolness, I think the bed with lots of layers, so that you've got like a throw or something on the bottom that you can pull up if you get cold, but you've got layers that you can just sleep with a sheet. I do think it's probably time, if you're in the position to do it, is to buy yourself some really nice sheets, trying not to use, man-made fibers and things that are going to wick away moisture and make you feel most comfortable. And then it's also about thinking about what you do before you even get towards your bedroom. So,
Sure.
not having really stressful phone calls with people that, wind you up, or, not watching some really scary, murder mystery on TV, or, documentary about a serial killer is probably not going to be conducive, or not having a really heavy meal or eating lots of food that are going to have, you're going to sit there, and we've all done it, eating the popcorn and the Maltesers, watching a movie, but then expecting yourself to, 20 minutes later to be trying to go to sleep. So it's just being very mindful about, your environment and what you're doing beforehand. You know, a lot of women will tell me that they can no longer drink alcohol. We don't entirely understand why. There is some studies going on about that now, but alcohol is often something that people struggle with in peri and postmenopause. They'll tell you that they get a terrible sleep, they get waking up during the night. So definitely avoiding alcohol. Caffeine's a bit of a no-brainer. We know it's a stimulant, so not having a coffee, late at night, so it's going to keep you awake. But, also other drinks. So lots of people will drink, fizzy drinks and Coke and things at night. And again, you're just giving yourself another stimulant and making it really hard to go to sleep. I think the other things are, trying to have a bit of a routine. We all think back to our teens, whenever we wanted, liked at the weekends to have a big sleep in and get up really late. But what we know is actually for sleep, it's really better to be consistent. So, trying, to have a reasonably consistent bedtime and a reasonably consistent waking up time. Otherwise, your body doesn't really quite understand what routine you want to have. And I think the reason that sleep hygiene is so important in this period of life is that look, we're already feeling exhausted. We're already feeling fatigued. We're already feeling not great. Going to sleep and staying asleep is already a massive challenge. So you want to kind of have all the other bits, all your other ducks in a row, so that if you do get that opportunity to actually go to sleep, that you can. I think also they say to try and keep your bedroom for sleep and intimacy only, and try not to have it for, TV watching or eating or whatever, or studying, so that you're not always associating your bedroom with something stressful.
Yeah, sure. And what do you want women to know about perimenopause and menopause?
I think for me, what I want people to know is I want them to understand what it is. And ideally, I'd love them to understand long before they get there, so that it's not, frying pan in the face kind of experience. And I think the other thing is that I want women to know that it's actually not something to be terrified about, because actually can be really proactive. So, it's about trying to get, you're eating great. So you're having your enough protein, and you're having your fiber, and, you're on your omega-3 fatty acids, and you're, hitting all those nutritional goals, and that you've been building your muscle, and that you're going into it with great bone mass, and you've got your mental health in a good place. So, maybe you've already found yourself a great psychologist who you talk things through with, and they're there to give you support, and that you've chatted it through with your family and your partner, so that that if you do start to go into a period of time that feels really, really tricky, that you're going to have an ability, or that you're going to have a bit of a deal with your best friend or your mom or your partner, that they're going to ask you like what is going on, and that you're going to be okay with that. So I think it's about being proactive and not being scared about it. And I think also knowing that there's so many positive things that come with this time of life. I think lots of women, and you can read it lots of places online, that people will say they've just got to the point where they're deep down much more comfortable with their opinions and who they are. They're much more clear about what their boundaries are and what they're happy to say yes and no to. And I think for a lot of women as well, it does bring some freedoms to explore, career or entrepreneurship or friendships or exercise or hobbies that they've never had time to do. So I think what I'd like people to know is that it doesn't need to be this doom and gloom thing, that it's going to be horrific. I think it's about getting a team around you, and, even just having a really good friendship group, or even an online community that you can ask the questions, and probably not to bury your head in the sand. Because even if you are one of these unicorns, and there are some who sail through the whole experience, the realities are that the postmenopause brings health challenges to all women, whether we like it or not. And it does change our trajectory of risk for heart disease, for osteoporosis, and also for probably dementia as well. And also for strength, for, being as fit as we want to be, increased risks as we get older of falling over, etc. So I think, go into this naively at your peril, and go in armed with as much information. And I think that you can not only survive, but absolutely thrive. This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.